This episode of Med-Surg Moments was made possible by Medtronic. For 70 years, Medtronic has been utilizing the power of medical technology to improve lives. Visit their website at www.medtronic.com. This is Evie, and I welcome you to this episode of Med-Surg Moments, the AMSN podcast. This podcast is an engaging look at the lives of and surrounding medical surgical nurses. According to the recent PRODIGY Study from Medtronic, 46% of patients receiving opioids on the general care floor experience respiratory depression. These common episodes are costly for both patients and the hospital, often extending the patient's length of stay. So what are the risk factors and how might we better mitigate these risks for our patients? With us today to help us learn that and more are Denise Shope and Jennifer Surprise. Denise Shope is an RCM&D risk management consultant with 31 years of extensive healthcare experience, 28 years of which she spent working in healthcare risk management. Denise began her career as a registered staff nurse at Geisinger Medical Center and also served in the roles of Director of Performance Improvement and Risk Management, as well as a patient safety officer. Jennifer Surprise is a clinical nurse specialist at the University of Kansas Health System, and she works with patients to provide individualized consultation to manage their pain while they are inpatients. In addition to working with patients and their families, Jennifer initiates system-wide education and policies regarding pain management and patient safety. So Denise and Jennifer, I welcome you to this episode of Med-Surg Moments.
Well, thank you, Evie. Thanks. We're really glad to be here.
We're going to start with either one of you, whoever wants to go first. What made you have an interest in nursing or patient safety in general?
Well, this is Jennifer, and I can go first and just tell you, if you ask me why I became a nurse, that's kind of a funny story. I'm not one of those people who had lots of family who knew nurses and kind of thing. I grew up watching MASH, and Margaret Houlihan, the head nurse, was my very favorite character. And that's really where I became enamored with the whole idea of being a nurse.
That's cute.
This is Denise, and I too grew up watching MASH and China Beach and a bunch of those healthcare hospital nursey kind of sitcoms, and also had a lot of childhood heroes. I guess you could say from the time I was a little girl, I always wanted to be a nurse. I always found myself playing that role, and I had a couple of family members who were also nurses, so it was sort of ingrained in me very early. I enjoyed the sort of the science part. I was that kid that was sort of always kind of taking little critters and trying to figure out how they worked. And I enjoyed figuring out how our bodies worked and the anatomy and physiology. And of course, I always loved the humanitarian side of it, just taking care of people who are at their most vulnerable moments. And I think that's just something I've carried through my entire career.
That's great. And both of you, I also grew up a little bit watching and knowing about MASH. So now that we have dated ourselves to our audience, let's tell our audience about an opioid-induced respiratory compromise. What is it and how can we better identify it?
Yeah, so the real definition of opioid-induced respiratory compromise is hypoventilation or hypoxia, meaning decreased oxygen saturation as a result of receiving an opioid. So your respirations are decreased, you're having some kind of problem because of the fact that you've received an opioid. So essentially how that works, if you're not as into pain management as I have been for a long time, there's opioid receptors. So they're in the brainstem, where we have a respiratory control center, and then also in the airways and some other areas. But Those are the main ones that we worry about in this process. So you take an opioid, and what happens is they really accentuate this inhibitory response in the brainstem. So your brainstem clicks down how your respirations are moving along. It decreases the rate, decreases the volume of your respirations. Along with that, you also get this ventilatory response in the airways. So the hypoxia and the hypercapnia, meaning your low oxygen, high carbon dioxide, that when that happens, you would normally start increasing your breaths. You would start ventilating more often. But when you take an opioid, that response is dampened. So you don't react as well. And then as the hypoxia continues, it gets worse. The hypercapnia, that your carbon dioxide builds up, then it just continues to worsen the situation, and your ventilation just gets worse and worse. So you end up with a lot of extra carbon dioxide in your system, low oxygen, and then you're just not breathing well at all. And that's what happens when we see respiratory compromise as a result of an opioid. It doesn't happen all the time, but there is somewhere between a low incidence of 0.1 to 0.3% all the way up into the 20s and 30%. But we really don't know for sure everywhere, because that number is probably low when we talk about the incidence of opioid-induced respiratory compromise in the hospital setting anyway.
As a risk manager, when I think of the term respiratory compromise or a patient who has had some type of respiratory event, of course, we're always thinking in terms of whether or not this event resulted in harm, and even more importantly, how it could have been prevented. So again, we're looking at this, and unfortunately, we know that it happens all too often. And of course, if it happens even once and there's harm as a result of it, as a risk manager, we're paying attention to that. We're looking at how could it have been prevented? Do we have best practices in place? And how has this impacted the patient? How has this impacted the nurse and the organization? So we're looking at it through the lens of both patient safety and risk management. Unfortunately, we know it happens all too often. And at the same time, there is a percentage of patients who are truly harmed as a result of these events also.
We want to focus on patient safety as always. And from the facility side or from the structural side, we want to decrease the risk of harm that any of our medical procedures may inflict on our patients. So having that in mind, in particular, this population of patients who have taken opioids, noting that they have a higher risk maybe of respiratory compromise, can you tell our listeners and our audience about the PRODIGY Study?
The PRODIGY Study is focused on the prediction of opioid-induced respiratory depression using monitoring, continuous monitoring. There's lots of guidelines out there from the Institute for Safe Medical Practices, CMS, the Joint Commission. They all say that you need to identify your high-risk patients in order to put them on continuous monitoring, because we know that continuous monitoring of patients who are at risk for opioid-induced compromise will do better because we can capture them earlier if a problem starts. It's determining that high risk that's the problem. Back in 2012, the Joint Commission came up with a Sentinel event alert for safe use of opioids in the hospitals. My hospital, we went through it step by step. We did a gap analysis. We tried everything we could to make sure we were getting the right information to people. And one of the big parts of that Sentinel event alert was there were 12 features that you were supposed to look at for high-risk patients. One of them was increased opioid dose requirements, and another one was no recent opioid use. So the question of the day back in 2012 was, which patient would either have none or some? And how do you wrap your head around that and decide that they're at high risk or not? So essentially, the goal of the PRODIGY study was to find an actual risk prediction tool in order to clearly denote those patients who are at high risk, because we want to be able to make sure that we are making those decisions correctly on how to treat them, knowing ahead of time what the providers need to do to preemptively manage their pain after surgeries and procedures. And then you also need to know that continuous monitoring is not available for everyone. Not all hospitals and health systems have it. So we have to identify exactly the correct patients to get that exact monitoring so that we know we're doing the right thing. So The PRODIGY study went through and really tried to identify a risk prediction tool.
So can you tell us about what those risk factors are or who fits into the high risk categories?
In the study, they ended up with about 1,300 patients from across the world and put all of these patients on these continuous monitors. And were able to look, as the monitoring was being done, they were able to identify different variables in the patients who ended up having some kind of respiratory event, meaning low oxygen saturation, apnea, low carbon dioxide levels. So they reviewed that data and they were able to collect it. And they found there were about 5 variables that really stood out and that showed significance in the indication of risk for the opioid-induced respiratory compromise. Those 5 were greater age, greater than 60, male sex, gender, opioid naivety. So that whole idea of do they use opioids or don't they, if the patient has not had opioids recently. Sleep disorders, so sleep disordered breathing, obstructive sleep apnea, that kind of thing. And chronic heart failure. So those are some of the top risks. Now, that doesn't eliminate all of those other risks that we identify along the way, but those were some of the ones that really stood out in this study anyway.
So those were the top 5 risk categories. What are some of the early signs that these patients may be in respiratory compromise?
Yeah, well, the idea of being able to monitor that select group of patients based on this risk score, based on these factors, is really key because now, as Jennifer explained, it really gives nurses and all clinicians a way of making a decision about who should be monitored, especially on those med-surg floors where, as Jennifer said, it's just impractical to place a monitor on every single patient. There's lots of reasons why that doesn't work. But now that we have that tool, and now that we're able to identify those patients who are at greatest risk for respiratory compromise, we can make clinical decisions about placing those patients on a monitor. And once that patient is on the monitor for the capnography, we can now then identify patients earlier on, as Jennifer said, who may be having difficulty with their airway due to the fact that they were opioid naive or they're continuing to receive some type of opioid postoperatively. The capnography will be able to identify patients who are having increased levels of CO2, and also we would continue to monitor things like pulse oximetry as well as respiratory rate and other vital signs. But again, now we're able to really help with assessing that patient early on and intervening early on before the patient actually gets into trouble. And unfortunately, in my risk management world, we often hear about the cases where patients have some type of anoxic event, either due to a respiratory arrest or even, unfortunately, a death. And so again, even though that's a small number of patients, one is too many. And we know that when those events happen, when we have patients who are harmed as a result, it's very difficult to defend those cases. And they're just very difficult cases for everybody for all the obvious reasons.
So let's play a little scenario, I guess. I'm a nurse on a floor, a med-surg floor. And I do know that not all med-surg floors have a monitoring or a capnography monitor or even telemetry. But let's just say I'm a nurse. I have a patient on the floor. I want you to kind of paint the picture for our audience as to how a nurse might use this tool to help keep her patients safe and to be able to identify those early signs and the risks so that we can get the patient to the proper care level.
I can speak from a really long time ago being a bedside nurse, and we didn't think this way. So back in the day, you took what you got, you had the patient that you had, and you just dealt with what as it came along. We didn't have rapid response teams or anything at that time. If I had a patient come back from surgery, I just monitored them. We took their vital signs, and if something happened, well, that's a shame. Let's try to treat it at this time. What we can do now is we can say, okay, if we don't have a continuous pulse ox, we don't have a capnography monitor, we can say, I have received this patient. Let's say we get a report sheet, okay? I get a report sheet from PACU that says the patient is 75 years old, male, has no real history other than a little bit of heart disease, and he does have sleep apnea, and so he uses a continuous CPAP at home when he sleeps at night. those are some things that pop. So things look in my mind. I can look and say, is this an older person? Yeah, it is. He's in his 70s. He's a male. So that might be something to keep in my head. He has some sleep apnea. Does he have his CPAP? Is he going to use one while he's in the hospital? He has had some heart disease, so we need to keep that in mind. And look at his medication list. Has he ever been on a pain medication before? Has he used one every day or in the last couple of weeks? And I can say, you know what, this person, because I know that these 5 variables might be something that would be concerning if I start giving him morphine or fentanyl or hydromorphone or whatever we give this patient postoperatively, particularly in that first 24 hours after a surgical procedure or some other procedure where they've received anesthesia. That is a period of time when I can say, you know what, this is going to be a person I want to keep an eye on. I'm going to monitor this patient more frequently. If I can't get in there every so often, I'm going to have somebody else check on them. We want to make sure that we're trying to wake them up. That's the other thing I try to teach our nurses, that we like to say we want to help people sleep. We want them to be comfortable after surgery and we want them to sleep. But we also have to make sure that there is a point in time they're able to wake up. So I'm going to be monitoring them. If it's a night shift, I'm going to go in and just pop in and put my hand on them and say, hey, just wanted to check on you, make sure everything's okay. Those are the things that we can do as nurses, and we have no technology at that point. That's just nursing 101. I'm monitoring my patient, listening to their heart and lungs, making sure that you're looking ahead of time at what's going on. You can go in, you can check on a patient, and 5 minutes later, they're not breathing. And so you have to make sure that you're actually having a conversation or waking them up or really making some headway and having that interaction to know that the patient is not decompensating at that point. But I think that just having some idea about those really important high-risk variables is going to be something that a nurse could use no matter if they have their monitors or not.
Right, Jennifer. And those are not just basic skills, but they're also critical skills. And I think for bedside nurses in particular, putting those pieces together, again, getting back to the basics and looking at the risk factors that you've mentioned as it relates to respiratory compromise, and then applying that to that whole patient. Where is that patient coming from? Is that patient coming from the PACU? Have they had the opioids and all those other factors that we know do play a part on the respiratory system? In addition to that, I would like to add, Jennifer, to what you just said, making sure that we're documenting that we have made contact with that patient, that we attempted to awake the patient and have that conversation and document that. Denise, as a risk manager, I want you to talk a little bit about the role that a risk manager plays as it relates to making sure that the evidence-based practices are being implemented when we're talking about respiratory compromise, particularly for these patients.
You're both absolutely right. Nothing replaces good nursing care, good assessment skills, good critical thinking when it comes to caring for your patients. All the monitoring in the world isn't going to replace that nurse who can assess the patient and really identify what's happening with that patient clinically and make good decisions based on her or his assessment. From a risk manager standpoint, I think that risk managers can really play a key role in partnering with their clinicians and with the nurses, and to really proactively look at what's currently being done. Again, I emphasize the fact that this is a topic that every hospital risk manager should have in front of them. It should be something that they're having a discussion with, either whether it's their anesthesia department or their DON or the med-surg nurses, the clinical instructors. Start asking questions. What are we doing in our med-surg units? Look at some data. Have you had some near misses? What's happening with your respiratory response team? What types of calls are they getting to? Do we have a lot of near misses in our hospital? And begin to really do that risk identification, which is the first step of any risk management process. And then begin to ask the questions, where are we now and where should we be going as far as best practices? sometimes it's very difficult to make the business case for buying or purchasing capnography or using capnography on a med-surg floor. But if you can begin to look at the data and do that type of an analysis and say, no, we're not going to use it on every patient, but we're going to use it on these select patients based on this criteria. And yes, there's going to be some cost involved with that and ongoing training and education that needs to be done when using capnography. But make the business case for patient safety and for risk management, if you will, and then begin to have that conversation, not only with your clinical colleagues, because most times they're like, yeah, we're on board. We want to implement best practices. We know what the science is saying. We know what the PRODIGY study is about. But how do you make that business case to maybe the administration that, look, we really need to change the way we're doing things, and it's going to require a change in standard operating procedures, and it may even cost us a little money, but here's why it makes sense. So again, I think the risk manager plays a real key role in helping to coordinate that work with the clinicians, with the nurses, with the anesthesia, with the surgeons, and really begin to do that risk analysis, identifying what is our risk, what's our data telling us. We know what the research says, but what's happening in our own organization, and what are the gaps in our current practices. We may have a great policy in place, but are we following it? And Jennifer and Evie, you both know this because you're at the bedside. It's been a while since I've touched a patient. I kind of sit back in my risk management role, but you could have a really good policy in place, but it may not be implemented all the time. You have to ask yourself why. Why aren't we able to do what we say we're going to do? And then again, look at all of those organizations that Jennifer mentioned, the Joint Commission, the National Patient Safety Foundation, and all the others who say, this is what you should be doing for those patients. This is the monitoring that you should be doing for those patients. And then really begin to drill down and say, well, if our practice doesn't match what the standard of care is, how do we get there? And if we do have a policy in place and we're not following it, why is that the case? And again, begin to think about solutions of how you can really fill those gaps.
Those are important things to think about because as a bedside nurse, sometimes we don't have some of the data points or the particulars that you may see, Jennifer or Denise. And so I want to ask, what are some specific economic facts or data that a bedside nurse could see or maybe should see or will see when we are caring for these types of patients, these respiratory compromised patients, when we are making their safety and reducing the risk to them a priority? What are some important economic factors that we can talk about?
Well, the PRODIGY study and other similar studies that have looked at respiratory compromise cite a lot of different data points as far as frequency, how often this happens on med-surg units. And so reviewing that literature, I think, is really helpful. I'm all about doing literature reviews before we start any type of improvement project, whether it's risk management, patient safety, or quality. We know also that there's been a couple of studies in the last few years around claims and lawsuits related to patients who have been harmed or injured as it relates to respiratory compromise, patients who have suffered anoxic events or even death as a result of that. Those claims are very expensive. What I mean by that is the cost not only to defend those claims, but the indemnity, the damages that are paid on behalf of those claims are very high. And so in risk management terms, we call that severity. What is the severity of these types of risks? And so that's a high severity type of claim. Imagine a 60-year-old male patient who comes in for elective surgery who doesn't have any type of history of opioid use and has pretty straightforward, uneventful surgery, comes out of surgery and has respiratory compromise, respiratory arrest within the first 24 hours of surgery postoperatively, and ends up with some type of permanent neurological damage because of the anoxia. I mean, we may have rescued him. We may have been really good at doing the CPR and preserving his life, but now he's got a permanent damage. That's a really difficult case. Even if the nurse was vigilant, even if the nurse was doing, Q2-hour vital signs and observing the patient, that's a really difficult case to defend in a court of law. So I could go on and on about claims. I won't, but that is important data. And there is data out there around that as well. So we're looking at both frequency, how often it happens, And I go back to looking at your own hospital's data. Talk to your quality people. Ask them, is anyone monitoring adverse events? Talk to your risk manager about how many times have we seen or how often do we see actual respiratory compromise that harmed patient, and also those that are near misses. I always say I'd rather be good than be lucky. So those near misses may be opportunities to learn and improve on. Don't wait for the one event or the root cause analysis and react to that. Try to be a little more proactive and look at what is your current practice, what opportunities do you have to improve that current practice, and look at those near misses as well that may have occurred. And I'm telling you, your data's out there. Somebody in your hospital has it, whether it's quality or risk, somebody has it. Have a conversation with those individuals in your organization and then start asking some key questions.
I absolutely agree with everything Denise just said. And I happen to be one of those people who collects all of that data and where I am. So I have been monitoring reversal use for a very long time. So looking at your naloxone use, looking at how often a rapid response is called for a respiratory compromise situation. You asked about the finances, putting dollars to that. We find that if you have this issue, you end up with longer length of stay, you have transfers to higher level of care, to ICUs, and maybe even having to transfer to a larger hospital. So those things will all come into play with the finances as well. So if you have that data too, you can put that together as your business case as well. We all want to do good. We want to do the right thing, but if you want to put together some kind of a plan moving forward, having your own data set next to those guidelines and put those to the people who are in charge and say, this is where we need to go. I think that's the way to handle that. That's how we did it here.
So what exactly does a proactive risk assessment look like?
A risk manager in your organization is always looking to do things proactively. Unfortunately, a lot of times we end up doing things reactively. In other words, we have an unfortunate serious safety event where a patient has suffered injury or damage or is harmed as a result of respiratory compromise. We'll do a root cause analysis. We'll go back and figure out what happened, why did it happen, how do we prevent it from happening again. But a proactive risk assessment is taking proactive steps to prevent that from happening. Again, nobody wants to harm patients. No nurse, no physician, nobody ever thinks about harming a patient. That's just not what we're about. But again, sometimes we're put into systems and processes that don't allow us to do the right thing. So a risk manager can really help you make the case for improvement, make the case for doing the right thing when it comes to patient safety and mitigating risk. So there's a whole process that risk management will go through, and that person in your organization can lead and facilitate and coordinate that work in a way before a patient is harmed, before there's an adverse event, especially when you're trying to implement a new best practice or really change policies and procedures based on the science that's out there. And that's the beauty of the PRODIGY study. We now have good, hard scientific evidence that says if you do this, then you'll decrease the risk of respiratory compromise. And again, it's something that every organization should be looking at proactively. Don't wait until you have that one case or that near miss and you go, wow, we should be doing something differently.
Jennifer or Denise, did you have any last words for our audience?
I used to be a med-surg nurse back in the day. Yeah, I'm a little older than probably a lot of you listening to the podcast today, but I still have those critical decision-making skills and I still keep an active nursing license. And even though I do risk management and I don't necessarily work at the bedside anymore, I'm very cognizant and very aware of all of the stressors and the needs that nurses are faced with and all of the issues that you're faced with at the bedside. I, again, would strongly encourage you to knock on your risk manager's door, go have a cup of coffee with him or her, and begin to have that dialogue. Because the risk managers, I'm telling you, are very interested in patient safety and mitigating risk. And they're looking for those clinical champions, those nurses and physicians and respiratory therapists who really want to do the right thing. And sometimes doing the right thing is not always easy, especially if you've got, again, a lot of competing projects, competing issues for capital in your hospital. Lord knows we're seeing that today. So work with your risk manager. They can be a really good person in your organization to help lead that effort. You don't have to do this in isolation, and you don't have to be the Lone Ranger sort of out there trying to do this alone. The risk manager can really advocate with you and for you and lead this effort. So plug for risk management out there.
Denise and Jennifer, it's truly been a pleasure having you on this episode of MedSurg Moments, a very important episode. Thank you for sharing your time and expertise with us.
Well, thank you. It's been great. I appreciate the opportunity to share and look forward to working with you again.
Thank you. I've enjoyed it. Thanks a lot.
We look forward to connecting with you on the next episode of MedSurg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, topic ideas, and feedback via our official MedSurg Moments email address, amsnpod@amsn.org. That's amsnpod@amsn.org. We'd also like to remind you to become a member of AMSN or renew your membership at www.amsn.org. You'll receive lots of cool benefits and perks, such as discounted pricing on the annual convention and continuing education. We encourage you to help us spread the word and subscribe to the MedSurg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review and recommend MedSurg Moments wherever you get your podcast to help us reach even more listeners. We also invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages. And don't forget to add hashtag MedSurg Moments to your post. Simply enter AMSN in the search field on any of these social media platforms to connect with us. The content within the MedSurg Moments podcast represent the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses. Until next time, I'm Evie, and always remember, MedSurg Moments is a moment in our lives, a moment in our MedSurg careers that makes a huge difference. This episode of MedSurg Moments was made possible by Medtronic. For 70 years, Medtronic has been utilizing the power of medical technology to improve lives. Visit their website at www.medtronic.com.